Okay, so chronic neuro. Yes.
Sorry, I got no Wi-Fi, but I promise I'm here.
All right, we'll get you enrolled. Okay. Yeah. So take roll if you haven't already. But chronic neuro. All right. So neuro is a little bit complicated because there's a word for everything in neuro, and they use their own language. They're not as bad as hematologists, where they use Roman numerals, but they are still bad because they named their cranial nerves after Roman numerals, unfortunately. So we will have to apply our anatomy a little bit to know the vasculature of the brain, because the vessels of the brain can get blocked or they can rupture, and that's called a what? That's called a stroke, right? A CVA, a cerebrovascular accident. The accident is that it occluded, like a CAD, PAD situation, or it ruptured, like a hemorrhage, okay? And hypertension also causes both of those, okay? And then we have other anatomy things that, like different nuclei that might get affected. Different nuclei are responsible for like memory. So Alzheimer's disease, AD, affects memory. PD affects one specific nucleus, the substantia nigra. So that's responsible for secreting dopamine. So one of our jobs, or one of our medications that we use for that is to increase dopamine. It's not one, there's like 8. So unfortunately, so there's a lot of dopaminergic medications for Parkinson's disease, for instance. And then we have MS. MS is throughout the whole CNS. It goes all the way through the CNS and the spinal cord. MS we're going to talk towards the end because it's going to apply everything we learned about, because it can cause any one of these symptoms. It can affect the hippocampus that Alzheimer's affects. It can affect the substantia nigra that the Parkinson's affects. It can affect many, many different areas. All right, so in pink here we have the CNS. The CNS is your brain and spinal cord. And these diseases in pink only affect the CNS. They don't go outside the CNS. The ones in yellow, however, do. So yellow diseases including GBS and myasthenia gravis. So, or Guillain-Barré and myasthenia gravis. So we'll talk about those two diseases. Myasthenia gravis affects the neuromuscular junction out here, and that's part of the motor system or the sensory system of the brain, of the neuro. Is that motor or sensory? Myasthenia gravis, or neuromuscular junction, I should say. This is the motor system, right? So the motor system comes from somewhere in the brain. I changed color. It comes somewhere in the brain, it comes down, and then it goes out to a skeletal muscle, all right? And we can control that voluntarily. So we get fatigued when we have myasthenia gravis. We have the inability for that muscular junction to work, and then it stops working over time. Okay, until an important muscle fails. What's an important muscle? Diaphragm, right? You need to breathe. So that muscle can fail, and then now you might have to be on a ventilator. All right, so then we have Guillain-Barré. It affects the skeletal muscle fibers, the fibers going to it, not the actual junction itself, but the fibers going to it. And then stepping one step back is ALS, our last disease process. ALS just only works in the spinal cord and affects just the motor tracts in the spinal cord. So ALS is a disease not that is sensory, but that is motor. All right, sensory meaning that it's all the inputs from the periphery, all coming in from all kinds of different neurotransmitters. They're all going into the brain, right? So motor, not degenerative diseases, but motor dysfunction can be a problem with our neuro diseases or chronic neuro diseases. People live with these for a long time. And people can come to the hospital for an exacerbation of these diseases as well, or they just show up with a stroke, for instance. All right, so that's our first topic. It's probably our most heavily tested topic is stroke for the final, because it is very popular. It's a thing that happens many, many times. We have a whole American Heart algorithm, or the American Neuro Society has a whole algorithm that makes sure everybody recognizes that someone's having a stroke, and that they actually do the necessary steps to get them better. All right. You'll learn about the ACLS management of it, the emergent management of it in Med-Surg 3, but here we have to learn like how they present to the hospital and what the treatment would be, and then we're going to talk about the chronic complications of it. And we have to be able to recognize that, and to recognize that we have to learn the vessels and what the vessels perfuse and what those symptoms would be. So for instance, the anterior cerebral artery, the ACA. So the ACA feeds the front anterior portion of the brain, and that's going to cause symptoms of that area. So we have to learn what that area does normally. If you already know what it does right now, you're already ahead of the game, right? But otherwise, we're going to review that a little bit of that anatomy, okay? And then the MCA territory is another vessel, middle cerebral artery, that we're going to look at. The posterior cerebral artery we're going to look at. Facial droops are a really common thing that we look for stroke patients. And what's the acronym we always teach? So FAST, or be fast, right? We'll learn that MCA strokes have FAST symptoms and posterior circulation has BE, okay? So we'll look at those specifically. All right, and a CT of the head is pretty important because that tells you whether you have an ischemic stroke or a hemorrhagic stroke. Those are the two types of strokes. Which one's more popular, which is more common, is the ischemic, like 85% of them. But hemorrhagic strokes are very devastating. There's really no treatment you can do. It's just thoughts and prayers. There's no real fix you can do for it. You can relieve the pressure and let the brain expand outside the cranium, but that's about it. All right. We can remove some fluid, and that's taking the fluid out and make sure it's the right amount of pressure in the brain. That's more Med-Surg 3, but we'll talk about how we get to that. So hypertension can just burst an aneurysm that can pop in the brain, or a vessel itself can just become leaky due to hypertension, and then it just, it can rupture inside anywhere in the brain, really, right? So we'll talk about the different areas of the brain that it might rupture, and you get a CT scan that will tell you whether it's ischemic or hemorrhagic. And on CT and on X-ray, really, blood is white, all right? Blood will absorb the X-rays that you're shooting through it. Okay, so we'll talk about those different kinds of hemorrhagic strokes and ischemic strokes, right? And then the complications. What are the complications that might develop from someone who either A, recovers completely or does not recover? They usually end up with a deficit of some sort, right? A deficit means they're not at total function. They can't move their right arm, or they can't speak, or they can't understand speech, or they can't walk. Their ability to walk is impaired. And what's that called? Gait, or ataxic gait will be impaired, okay? And there's swallowing risks, and they can get aspiration pneumonias, they can be bedbound and immobile, and there's a lot of complications of immobility. And on the previous slide, we talked about all the different neuro things we're going to look at, and a lot of those lead to immobility. And immobility is an important thing to helpfully avoid. And if we can't avoid it, we have to consider goals of care, and whether we need to consider palliative care or end-of-life care for these patients. Okay, so here's a blood vessel that's about to rupture, and we'll be focusing on this little back half of the brain as well. The circle of Willis will be our friend, and we'll talk about how that's beneficial and what it kind of feeds. Okay, and then stroke is still up there as like this number 4, cause of death nationwide. So it's an important thing to look out for and prevent.
Lady Antebellum was the big winner tonight with 5 Grammy Awards. Rapper Eminem, the big shocker, winning only 2 despite 10 nominations. CBS 2's Serene Branson is live at the Staples Center with highlights and backstage coverage we're seeing for the very first time. Serene.
Well, a very, very heavy rotation tonight. We had a very Darrison, but let's go to Terrace Tazen, look for the head of the pit.
So she's having a stroke live on air. And that's a acute loss of function, right? It's a specific loss of function. It's not where you just get confused, right? That's not usually stroke symptoms, where you're just confused and you're altered and comatose and sleepy, lethargic. Those are usually like maybe medication related, electrolyte related, something going on. They're acidotic, their CO2 is high, something like that. Whereas a stroke is an acute, sudden onset, and strokes are not painful. 85% of them aren't. Hemorrhagic strokes are painful, but strokes are not painful. So people's like, oh, I'll just sleep it off. I'll see if I get better in the morning. Or, I couldn't talk last night, but let me just sleep it off and see if it gets better. And we have to recognize and teach them that, no, be fast is an important reason to come to the hospital, because it's time sensitive. We can try to fix it if we know the last known time well, the LKTW, last known time well, is going to be the line in the sand, and everybody has to say, well, when was grandma talking normal? Oh, 8 p.m. And then when did you bring grandma to the hospital? It's 6 a.m. and that's too late. All right, there's nothing we can do at that point, okay? But we can do certain things within 12 hours, certain things within 4.5 hours. All right, so overview of strokes. All right, so it's a sudden, right? All of a sudden, it's a focal neurodeficit. So what does focal mean? It's it's one specific thing is wrong, right? It could be multiple things, but one specific thing they can normally do is wrong, like speech or walking or being continent or being, having the ability to see. Those are specific things they should be able to do at baseline, and now we've lost that, okay, suddenly, all right? Happens every 40 seconds, right? And about 6 million people are living with deficits. It's 1 in 19 people get a stroke or die from a stroke, and it's the 5th most common cause of death in America. All right, so females are more prone than males, and stroke, again, is a disruption of blood flow. It doesn't matter how the blood flow is interrupted. It could be, again, a hemorrhage. It hemorrhaged out and it's not going to its destination, right? Or it's ischemic. There's something in the way, right? Most commonly, it's a clot of some sort. Okay, so blockage or bleeding are the two different reasons. Either hemorrhagic stroke, which is which one? Bleeding, and then or a ischemic stroke, all right, which is a blockage. Again, that's about 85 to 87% of our strokes. And then just looking back at the stats on who survives from a stroke, right? Of those who suffered a stroke, how many people survived at 5 years? 30% survived once they have a stroke of any variety. Those who have a hemorrhagic stroke, about 24%. But you can see we have a lot more options to fix people acutely in the hospital versus when they have a hemorrhagic stroke, there's not much we can do. Okay, so we talk about the different types of ischemic stroke, and we'll talk about those different ones. Our large vessel, and that's kind of what we're used to. That's with an impaired flow because of ASCVD. There's an atheroma in the way, and then all of a sudden the atheroma gets thinner and thinner and thinner, it exposes its collagen, and then a what forms? Embolus or thrombus? A thrombus forms, right? So a thrombus forms immediately, right? And that will then cause a occlusion of the blood flow to that part, to a certain part of the brain. And we'll learn those different parts, the middle cerebral artery, the anterior cerebral artery, or posterior, or the basilar artery system, right? So it is a blockage of flow. And there's different types of ischemic ones due to ASCVD, TIAs. Those are kind of lucking out. That's just lasts for 24 hours, all right? It's a stroke that they have the stroke-like symptoms, and then it only lasts for 24 hours and goes away, right? If it's 24 hours and 1 minute, it's no longer a TIA technically, right? But if all the symptoms dissolve within 24 hours, it is what's called a TIA. And actually, there's nothing physical they can see on MRI or CT scan that shows that they have a stroke of any variety. All right, but we know they have stroke-like symptoms, and they have probably risk factors. They're obese. They have a history of CAD. They have a history of diabetes. They have a history of hypertension. All these things are really playing the framework that they have a TIA happening. All right. If not, it could be it would then be called an ischemic stroke. There are also another subvariety of ischemic strokes called due to carotid artery disease. So our carotids. Those are the first branch up to the brain, right? We have an internal and external carotid. One goes into the skull, one goes outside the skull. So if we have blockage of the internal carotids, that's going to cause a stroke to happen, right? So carotid artery disease has its own management, which we'll talk about in Med-Surg 3, as far as like the surgery you have to do for it and other things. But it still falls under the umbrella of ischemic strokes. Okay, so we have large vessels, our large vessels being the MCA, ACA, PCA, and basilar arteries. So those 4 vessels we're going to learn the symptoms for each, all right, when we talk about strokes. The nice thing is that it's the same for ischemic and the same for hemorrhagic, right? They're as far as the symptoms are concerned, right? Once you learn the symptoms once, it's going to be the same symptoms every single time. If you have an MCA hemorrhagic stroke or an MCA ischemic stroke, they all have the same symptoms. All right, and then we have small vessel disease. Small vessels being are smaller than large, but they are small little vessels that are they get impacted. Like if you're going up to, where is it, Ridgecrest? I don't know why I think of Ridgecrest. You go in the beautiful city of Ridgecrest, and you're going over there's only one road into it, right? And you go that one road into it, and all of a sudden you start getting hypertensive, and you start, I guess, making the roads even more thinner and thinner and thinner, that you can no longer get to Ridgecrest, right? Everybody been to Ridgecrest before? Right. Anyways, so yeah, so it's like a small one little road into the town, and then once that road can get occluded and road can get more and more blocked, that will then lead to that town not getting its supplies. All right, so these are due to lacunar strokes. So hypertension is like where you have a you're damaging the roads to the little town, and the roads get more and more impacted and more sclerosed, and more smooth muscle develops and develops and develops, and that's going to then cause a lack of flow to that small town. Okay, so that's a lacunar stroke, and diabetes can do the same thing. Diabetes can cause that, what we said was hyaline arteriosclerosis. It causes smaller and smaller flow to that little town. So down here in the corner here, here's our lacunar strokes, right? So that vessel gets bigger and bigger and bigger. Not bigger as in vasodilated, but it gets narrower and narrower and narrower as in it gets more beefy and more bulky and more thick, right, over time. And that's due to damage from hypertension, damage from diabetes. It's not so much atherosclerosis, but it's more damage to that small vessel and small little areas in the brain, small little towns in the brain, small little nuclei in the brain don't get the flow they need, right? So those are lacunar strokes. And then we have cardioembolic strokes. So we've been, what's the word? We've been, what's my English? I've lost my English thesaurus. Alluding to these cardioembolic strokes a couple times, like we talked about infective endocarditis can loose a clot, and it can travel through the bloodstream. What's that called? When infective endocarditis looses a clot? It's called a septic emboli, right? Or an emboli could be a different form when it is comes from also from the heart, right? What would that be? Like AFib, right? So AFib is going to be a significant risk factor for stroke that we talked about in the first lecture of this course, right? So AFib is a significant risk factor. 20% of those who have AFib, 1 in 5 will get a stroke, right? An ischemic stroke. Why is it ischemic and not hemorrhagic? Because the clot traveled and it blocked the flow. It's ischemic. Ischemia meaning blockage, right? And we got a dilated heart. So we talked about with CHF, one of the complications with CHF is it gets so dilated that a clot can form it because the blood is not moving like it should, right? And that clot can form in the LV or the left atrium, and that can then, over time, get loosed into the bloodstream and flow all the way up to the brain, right? And then we have a DVT, right? So DVT can grow in the legs, and then that can then travel up to the brain. When would that happen? When we have a patent foramen ovale, right? So that PFO, the left right atrium, it has a little window into the left atrium, right? And that blood will flow from the right to the left. Okay, so that would be a DV. That's why we put patients on what kind of prophylaxis? On VTE prophylaxis, right? So venous thromboembolism prophylaxis. So we stop the clot from developing in the first place, and that will then hopefully, if it does get lodged, 20% of our patients have that patent foramen, and it will then travel up to the brain if they had no prophylaxis in place. Okay, so septic emboli, patent foramen ovale, and then we have cryptogenic, which is a fancy word for saying, I don't know what caused it. 30% of the time, we have no idea what the cause of the stroke is. All right, we know 20% of the time it is due to ASCVD, 15% due to hypertension and diabetes, and maybe cardioembolic by 20%, but 30% of the time we have no idea what the cause is. But there are other reasons besides the ones above. There could be like a physical clog, and we'll talk about this in next semester, Med-Surg 2, with lupus and other like sickle cell disease that will clog the arteries up to the brain. And then something you talk more about in Med-Surg 3 with global ischemia, global damage to the brain, right? When your O2 level is super low, the brain doesn't know what happened, it just knows the O2 level is low, right? And the O2 level is low to the brain, what's it going to do? It's not going to function, right? And specific areas can start shutting down, and especially with low blood sugar, right? If you have low blood flow to the brain or low blood sugar to the brain, it doesn't know what the difference is, right? It's just say, I'm not getting the necessary nutrients I need, and when the blood sugar is low, that's going to start mimic strokes. So one of the things we do with strokes-like symptoms is we always check what first? Always check a blood sugar first. That way we can identify, oh, it's an easy fix. We turn you around right away. And it's like Hollywood when you give blood sugar to someone with stroke-like symptoms with a low sugar, it's going to then just magically fix them right away. They're going to start talking normal. They're going to start, they can walk again. It's magic. Okay, so low O2, low sugar, and low blood pressure are also a low flow to the brain, and that's or low input into the brain, and that's going to cause damage. Okay, so then bleeding. So we have a section on bleeding. but hemorrhagic stroke is significantly worse than ischemic stroke. It's only 13 to 15% of your CVAs, but that's also due to what? Hypertension. Hypertension hits both, right? It's for different mechanisms, but hypertension causes both ischemic strokes and hemorrhagic strokes, right? So there can be some defects in the brain. There can be a lack of a capillary system, for instance, and we'll talk about that. And then a large ischemic stroke. So an ischemic stroke can lead to a hemorrhagic stroke. So we'll talk about the reason how that happens, but that's a significant find is when you have a really big stroke, it's blocking a lot of vessel territory, a lot of lobes of the brain are being blocked. You can see that on a CT scan that a huge portion of the brain is not getting blood flow. That portion of the brain can turn essentially to mush and become bleeding, all right? Become a hemorrhagic stroke. All right, so hemorrhagic strokes and ischemic strokes, right? We have thrombotic or embolic strokes. So embolic would be what example? It came from, did it grow or did it come from somewhere? It came from somewhere if it's embolic, right? It embolized from where? From a deep vein somewhere. So it came from a deep vein and it traveled up and it came across the atria up to the brain, right? Or they had AFib, right? That could be a reason for embolism. And we have ischemic strokes that are due to a thrombus just forming, and that's just due to ASCVD. We get more and more blockage of the vessel, and that will then eventually pop and then expose collagen, a clot forms, and now we have an immediate stroke, right? If a patient goes to the hospital, or sorry, to the urgent care or to the doctor really more frequently, they can then be identified as high risk and take what medication to prevent that thrombosis from forming. Can take an antiplatelet or anticoagulant. Antiplatelet called what? Called aspirin, right? So aspirin is for people that have ASCVD risk factors, right? So aspirin would be a great thing to be on before you have the stroke. If you're, you went to the doctor regularly and said, oh, you got a really high risk, you have obesity, you have these things, you have metabolic syndrome, and we should probably start you on aspirin, right? Otherwise, definitely after the stroke, we're going to be on aspirin. Okay, and what's a TIA? That's just 24 hours or less, right? It's a 24-hour ischemic or hemorrhagic stroke. Ischemic stroke, right? It's a warning sign that you need to change your ways and you need to start taking aspirin, right? That's a good reason to, it's a good wake-up call. Okay, and we'll talk about hemorrhagic stroke where we have rupture of the blood vessels going to the brain. All right. So we're going to switch gears and just talk about ischemic strokes, not hemorrhagic. We have a section just for hemorrhagic strokes, right? So ischemic stroke is a sudden blockage of blood supply to a vessel territory. And we'll talk about those territories shortly. But we have one of three things happening. We've got clot forming, a clot that has arrived as an embolus, right? Or we have decreased cerebral blood flow. So the blood flow to the brain does not have the adequate amount of pressure, right? It's not a good blood pressure to the brain. Or we have not enough blood glucose in that blood, or not enough oxygen in that blood, right? So low oxygen as well, or low blood glucose. So these are the kind of things we want to keep normal for any kind of neuro patient, because those are going to cause bad outcomes if we don't keep an adequate supply of oxygen and such, right? So this blockage of blood flow to the brain is essentially causing hypoxia to the tissues beyond it, right? There's no flow to this area right here, so it gives blockage right there, right? We have no flow to this area, right? That blue area, right? So no flow to that area is now has no oxygen, which is called hypoxia, right? And that area has become infarcted. So infarcted just means it used to mean dead, but it's not dead yet, right? So we can still turn it around. How much time do we have to turn it around? About 4.5 hours, right? And we can bust that clot. We can take that clot out, right? So that last known time well is an important thing to identify, so we can say, oh, you're within the window of us fixing this ischemic stroke, right? And this is not the only area that's affected. There's also an area outside of it that is also at risk of growing, of that infarction growing into this other area around it. That area being what's called the penumbra, right? Is tissue that's around it that is at risk because it's like, whoa, they had a lot of damage over there and they're now at risk and on alert, and that can then cause that area of infarction to spread. If we don't keep what normal? The blood sugar normal, the O2 normal, the blood pressure normal, we can put someone at risk for edema. All right, so you can see you have hypoperfusion, and that leads to infarction, right? That leads to lack of oxygen to the tissues. The lack of oxygen, well, your tissues keep water out of them, right? Your neurons keep water out. They're actively moving sodium, potassium, all kinds of stuff to keep the cellular contents normal. But if they die, all their cellular contents spill into the local area of infarction, right? And that spillage, what's inside of cells? All kinds of things such as proteins, right? And what do proteins do? They draw in what? Like albumin is protein, it draws in what with it? Proteins, just like sodium, just like glucose, just like it draws water into it, right? And that water is going to be edema. And is it good to have edema into a rigid, nice skull? No. So that's an important reason for cerebral edema. And you have edema in the skull, well now can blood, all this skull that is trying to expand, do skulls expand? Not after 18 months, right? You'll learn about fontanelles in peds, but and OB, but they're not going to expand, so now that's extra pressure inside the brain, and now blood flow can't even get to the brain, and that's going to make everything worse, right? So our goal is to make sure that no further cells die, and also to try to reverse the original infarction, right? So the area of infarction first is called the ischemic core, the area that's been infarcted, and then the area around that is the penumbra. And if it's large enough, all those cells keep rupturing, that can then lead them to fail, and they can pull on vessels nearby, and they can lead to what's called a hemorrhagic conversion. So large ischemic strokes can lead to a hemorrhagic stroke. Okay, so ischemic CVAs can evolve into a hemorrhagic stroke. Okay, so what are risk factors for ischemic strokes? Well, we kind of been studying ASCVD and all those things. So there's little questionnaires that can be given to firmly assess what percentage of chance they'll get for having a stroke. You don't have to memorize which ones those are. You should understand, it's really the ABCDs, right? So it's, are you taking aspirin or not? Is your blood pressure under control? Is your, what's the C? Cholesterol, what's the second C? Is your cholesterol, what's the second C? All right. Say again? Smoking cessation. So cigarette smoking, right? Cigarettes are under control because cigarettes are inflammatory, but also they're going to hypertensive, right? And then it's going on and on. D, D, E, E. All right? All these things are things we want to avoid, right? Specifically for ischemic strokes, AFib is a unique thing that will put someone at risk for a stroke, all right? And then all the ABCs that we've been talking about. Okay, so our goal is always make sure we are making the blood pressure great, the O2 great, the sugar great, so that we don't get further edema happening. All right, so vessel territories. All right, so the territories that the vessels feed. All right, so they have, when you have interruption to the frontal lobe is not going to work. You have interruption of blood supply to the occipital lobe is not going to work. Interruption to the temporal lobe, right? Parietal lobes, little deep nuclei inside the brain, those are not going to work, right? So you have to brush off your anatomy skills, remember what those lobes did, or just review in the corner right here, right? That's what those lobes did, or do, they still do them, all right? So we have our temporal lobe. What's our temporal lobe responsible for? Sight. There's a nuclei there responsible for sight, but primarily it's for usually speech, right? So if we have interruption of blood supply to our temporal lobe, just like our reporter friend, she can't speak, right? And it'd be nice if the vessel, like one vessel was a temporal lobe vessel. Here you go, temporal lobe only. But no, it's not. The vessel feeds this general area. It feeds a little bit of parietal, a little bit of temporal, a little bit of this, right? So that's what makes it a little bit challenging, is because the vessels don't feed the exact area you expect. But when we say, oh, that vessel feeds the occipital lobe, well, I can probably have occipital lobe problems. And what are occipital lobe problems? Can't do what? Can't see, right? Occipital lobe is the destination for our optic nerve, right? Which cranial nerve is the optic nerve? How many eyes do you have? 2. Cranial nerve 2 is your optic nerve, right? How many noses do you have? I got 2 nares. I got 1 nose, all right? So cranial nerve 1 is your nose, right? Of your olfactory nerve, all right? So then, but your optic nerve starts in your eyeballs and it goes all the way, or it doesn't technically start, it ends in your eyeballs, and it receives a signal from the universe and what you're seeing, and it deposits right back on the occipital lobe back there, right? What's this little friend right down here called, that little red piece? That's our cerebellum. What's our cerebellum responsible for? It's for balance and muscle coordination. It's how a ballet dancer can remember all their moves, or a piano player can remember all their moves without thinking about it, right? It's how you walk, right? When you ingest ETOH, which you'll do after the exam you took today, right? That's going to cause you to have impaired cerebellar activity, right? So you have a taxic gait. You have a gait that is not great, right? Not great gait. Okay, so the area of perfusion is going to cause your symptoms. And what we're going to focus on is the specific vessels that are being interrupted. Okay, so we have different lobes that is important to know about, like our frontal lobe. What's our frontal lobe responsible for? Movement, not so much. Frontal lobe is what differs us from apes and ourselves. It has higher executive functions. It's what makes us, when someone steals our lunch, we don't beat them up over it. Or oh, I guess they were hungry, right? Or you politely talk to them about it and you have a discussion, right? So that's what our frontal lobe is helping us differentiate, okay? And there's such thing as when you have a left versus right-sided stroke. We're not going to focus too much on that, but your left-sided strokes, they affect all the things the left side of the brain is responsible for, which is L for language and L for linguistics, L for logic, and one letter up is M for math, right? So all these things are what the left brain does. So when someone has a left-sided stroke, you can expect those things to not work, right? They're not able to do math well. They're not able to do language well. They're not able to do, not able to talk well, okay? They have dysfunction of talking. What's that? What's the fancy word for that? Aphasia, right? So aphasia meaning talk, not phasia with a G meaning swallow, but aphasia meaning that they can't talk, right? They can't talk good. All right, so then we have the right hemisphere. Right hemisphere is more for creativity and your emotions, recognizing faces and such. So when you have right-sided strokes, sometimes they can, they don't recognize a face. And the fancy word for not recognize a face is called prosopagnosia, right? So they can't recognize my face, right? You'll see this a lot more with patients that have Alzheimer's disease. They don't recognize the faces of their loved ones, okay? So that's right versus left strokes, or right versus left hemispheres. When you get a stroke to one of those sides, you're going to get symptoms because of it. But usually the symptoms you can identify, like when someone comes to the hospital with a right-sided stroke, it's like, okay, do this math problem. Okay, talk to me. So you do kind of assess their aphasia, but it's like, okay, go ahead and draw this painting real quick, right? That's not going to be our priority. Our priority is to identify what vessel it is by the specific stroke symptoms from that vessel not working, right? So we're going to talk about this vessel that's affecting what lobe is this? We cut the brain in half right there. That's the temporal lobe, a little bit of parietal lobe as well, right? So that temporal lobe's not working, right? That's the right temporal lobe. That's, yes, it can affect art and such, but that part of that lobe is not working because the vessel feeding it got blocked, right? Or it can hemorrhage, okay? So that's the middle cerebral artery. So we'll talk about middle cerebral artery symptoms, okay? And then we'll talk about laterality on the next slide. And laterality can get a little bit confusing because the left side of your brain controls the what side of your body? The right side of your body. There's a few exceptions, but for the most part, that is accurate. Okay, so laterality coming up next. All right, so functions and dysfunctions. All right, so laterality. So you can't just say left versus right to a neurologist. You have to say contralateral and bilateral and ipsilateral. So ipsilateral means the same side. So you have deficits on the same side. That's called ipsilateral. So an ipsilateral vision loss or ipsilateral eye movement or eye gaze deviation, or they have bilateral problems. And when you have bilateral problems, that's pretty bad. That's not a good sign when someone has bilateral problems, right? Especially when it's considering strokes. That means it's a huge stroke, okay? But usually strokes are contralateral for the most part. So contralateral means it's the contra meaning opposite, right? Opposite lateral means side, contralateral, okay? So contralateral, then we can break into motor symptoms versus sensory symptoms, right? Because when we send a signal down to our left foot, it comes from what part of the brain first? Left side or right side? It comes from the right side. Where in our brain does it come from? It's an existential question. Where's the thought to move my left foot come from? It comes from the top parietal lobe, right? So your parietal lobe has a little central area right here. The first half, the precentral gyrus, is for motor. Postcentral with an S is for sensory, post, right? So when we decide, hey, it's time to move my left foot, we say, send a little signal, we get the inkling right there, we will it into being, and that signal will then travel down our brainstem, right? And first it kind of stops in the thalamus. Thalamus is a big operator center, and it will then go down my spinal cord. Before it hits the spinal cord, though, it's going to cross over, right? It's going to cross over to the other side of the body, because we know that if it starts on one side, it's going to go to the other side, right? So we can't just say crosses over. That'd be too easy, right? In neuro terms, they like to make up their own words, or they like to use Latin and Greek. So what's it called for turning over or crossing sides? When you're going to merge lanes, you're going to cross over to the next lane. What's the passenger princess going to say? Decussate to the right, right? So decussate means to cross over, all right? So that's an area of decussation, right? And they call it the pyramids there. There's no pyramids to be found, but it's specifically in the medulla. So the medulla is the area that all those nerves will decussate, right? Goes from one side to the other. So they decussate from this is a impulse that we created on our left brain, right? And we're going over to the right foot, let's say, or right hand, okay? So it decussated. And then that's a motor signal or a sensory signal? Which one? That's a motor signal, right? So a motor signal can get impaired, right? For one, I could just maybe not just, that area of the brain could then be ischemic, right? That area could die. Or when we talk about other neuron diseases coming up with other chronic neuron diseases, our muscle junction might not work, or we might have a spinal cord problem, right? Like an ALS, for instance. But when we talk about strokes, right now we're talking about the OG up here, right? That area of the brain does not receive the blood flow it needs, whether it be ischemic or hemorrhagic, and that's going to cause ipsilateral or contralateral leg problems. Contralateral, because it did what? Because it decussated, right? So not desiccant, that's what's found in your kale chips, right? But decussated, all right? It crossed over at the where? At the medulla, and that's important because we have cranial nerves. A lot of cranial nerves start above the medulla, and they don't decussate, right? So we'll talk about those. But when you have motor symptoms, right? Well, if that motor nerve doesn't work, what kind of symptoms will you get? That muscle cannot work. First, it might be weak, right? And then it just doesn't work, right? But you're in neurology town now. You can't say it's weak, right? You have to say it is. All right, so it has, there is recovery here, but you got paralysis is the ultimate outcome, is that we have failure of that muscle. And then the neurologist comes in and looks, well, what's the failure? Was it a stroke, or was it ALS, or was it Guillain-Barré, or was it myasthenia gravis? So we'll look at those different problems, right? But we have a motor nerve problem. First of all, the muscle is going to start getting weak, and then it's going to wave goodbye. And how do muscles wave goodbye? They don't just wave, they fasciculate, right? So fasciculations means it's going to, like when you're trying to lift up the weights for your significant other, like, look, I'm super strong, and you're like shaking, right? That's fasciculation, right? That's your muscles waving goodbye, because you're going to fail really quickly, right? Hope you don't get paralyzed after that. All right, so that is the motor signals, right? And those motor signals are going outward to the muscles, right? They're going outward to the muscles, but we also have sensory signals that come from the muscles, from the periphery. We have sensation, temperature, vibration. All these things come from the periphery and go up to the brain as well. And it's going just right next door into the post-central gyrus, right? So we have like a little heat sensors in our fingertips, and those little heat sensors are going to feel heat, and that will then come from our periphery right here, right? It's going to go up the spinal cord, and then it's going to do what? It's going to decussate, right? And it's going to then land on a gyrus, right? And that's going to be our sensory signal. And if we have a lack of sensation, what's that called? Like just a little bit lack of sensation with like pins and needles, that's called Paresthesia, good. But if we have complete loss of sensation, that's called anesthesia, right? Paresthesia to anesthesia, right? We have an meaning without, so without thesia or sensation. All right, so we have numbness first, paresthesia, and then anesthesia. We might have decreased pain where we can't feel pain on one side, right? We have decreased vibration sense. These are all different things you learn as a RN. You learn what's called a stroke scale, and you assess all these. You get a little pin out, not like a pen to write with, but like a pin, and you say, hey, can you feel it over here? Can you feel it over there? And if they can't feel it on one side, that area has lack of sensation, right? It could be because of a stroke. Okay, and then this is all according to what's called the homunculus. And what's a homunculus? First of all, it's nightmare fuel. That's what it looks like, right? That's a homunculus. So it has a huge face like that, a huge arms, right? And that is then stretched across those gyri, right? So it's stretched across here, stretched on the other side. And it has the same layout for sensory and motor, which is nice, right? So when we have a lack of flow to this area right here, right? This area fails because it got ischemic or hemorrhagic. That means we have lack of flow to the what? To the arms, or lack of flow to the legs. I should be more specific, right? So lack of flow to the legs. Also lack of flow to the what? To the genitalia. So they get what symptom? Incontinence, right? So if someone presents with incontinence, they might have a lack of flow to that specific area right there, right? And then we have, it's called a distribution of the vessels, right? The vessels feed different areas of the brain. Certain vessels feed the arms and face, and that's your middle cerebral artery, which we'll talk about. All right, so we have like face drooping, or we can't feel our hands good, we can't talk good, right? Because our tongue doesn't have the motor control that it once had. That's going to lead to abnormal speech or aphasia, right? Also, abnormal speech is also called what? If I can't articulate things, it's called dysarthria, right? Dysarthria means I cannot articulate things, okay? So aphasia means I can't speak words good because the temporal lobe is what is responsible for our speech, right? The formation of words. For me to articulate words to you right now, I have to get the words from my Wernicke's area. I have to then associate it to my Broca's area, and I then have to articulate it, right? I have to find the words, and then I have to then articulate the words. Okay? So these are aphasias that can happen, where I can't say things well. Okay, and then we have anomia, that can't find words. Alexia, I can't understand words. And alexia is going to come more into play when we talk about Alzheimer's disease. Alzheimer's disease, they can't understand what you're saying. All right. And then perseveration, that happens with the deep nuclei start getting affected. Perseveration, that's when the deep nuclei are affected. Perseveration, that's when the deep nuclei are affected. Perseveration is when the deep nuclei are affected. So perseveration is the repeating of yourself, right? So perseveration is when you have you have an abnormal way you keep repeating things that you want to say. Whereas like echolalia, you'll see this more in psych, where it's like parodying something. Someone says something like Alexa, right? And then you start saying the same thing over and over. You seen those parrot TikToks? No, just me. All right. So anyways, you're gonna have you're gonna repeat back what they say. Okay, what someone has said. All right, so aphasias, they can be global, where they can't understand the words or they can't speak the words. That's global, all right? Nothing coming in and nothing going out. Or it could just be what's going in. They can't understand the words that people are saying to them. That's called a receptive aphasia. So receptive meaning they can't understand the words, right? Whereas not be able to speak the words, they have garbled speech. They can't speak it well. They can't find the words, or they have word salad. They choose the wrong words, the wrong situation. That's called a expressive aphasia. They can't express themselves that well. Okay, so this is laterality and also aphasia. So next thing we're talking about is the different regions of the brain.